Hi friends, welcome to Pain Policy Practice. The last few videos we discussed about living with chronic pain, which is our first pillar. So continuing on with our discussion of the second pillar is clinical chronic pain management. So let's discuss some of the chronic pain workup, diagnostic workup, including labs, imaging, nerve conduction tests, and diagnostic blocks. Now here's the reality. The biggest mistake in chronic pain is not missing a diagnosis. It's confidently diagnosing the wrong one, because in chronic pain, imaging findings, lab abnormalities, and even test results do not always equal patient's pain. Now let me repeat this. In chronic pain, imaging findings, lab abnormalities, and even test results do not always equal patient's pain. So today we're going to walk through a structured diagnostic workup for chronic pain, including labs, imaging, nerve studies, and diagnostic blocks. And more importantly, when not to order any of these. Before ordering anything, you need a framework. Every chronic pain, like when you evaluate a patient, should answer three questions. What is the pain generator? Is there ongoing tissue damage? And is there nervous system sensitization? Because chronic pain is rarely just structural. It is often nociceptive, neuropathic, centralized, and frequently a combination of all three. So before you do labs or order labs or imaging studies or do any of those diagnostic blocks, your history and physical exam are the highest yield tools. Key history elements are pain localization and radiation, quality of pain, burning, aching, stabbing, the timing and triggers, the functional impact it has on the patient, response to prior treatments. And physical exam, focus on neurological deficits, allodynia, hyperalgesia, range of motion, mechanical reproduction of pain. If you skip this step, everything else becomes noise. Now let's deep dive into all the clinical reasoning, because this is where most diagnostic errors happen. Number one, focus on comorbidities. Clues on one of the most important and often overlooked steps is this: not documenting comorbidities, but carefully document them. You just don't list them, but understanding what they imply, understanding the complications of comorbidities. Comorbidities are not background noise, they're diagnostic signals. For example, a patient with type 2 diabetes who presents with burning pain in the feet and axial low back pain as well likely has painful peripheral neuropathy from diabetes and lumbar osteoarthritis. So that's two separate pain generators. That's two different mechanisms, and that's two different treatment strategies. So most patients come up with multiple pain generators, and this leads to a key principle. Can patients have multiple pain generators? Yes, absolutely. And a combination of all three, nociceptive, neuropathic, central sensitization. They may not just have one diagnosis, but overlapping mechanisms of each of the nociceptive mechanism or a neuropathic mechanism or a central sensitization mechanism. And even if you miss one, your treatment will be incomplete. So identifying all pain generators is essential for effective chronic pain management. Next is substance use history. Another absolutely critical and sometimes uncomfortable part of the history is to inquire on substance use. You must always ask about alcohol use, nicotine use, any illicit drugs. And it's not to judge the patient, but to understand the risk, physiology, and treatment response, because substance use can alter pain perception, impact medication, and it increases the risk with opioid therapy. And what is the role of sleep and sleep apnea? Sleep is not optional in chronic pain. It is absolutely foundational. Sleep is not just rest, it is recovery. When sleep is poor, pain sensitivity increases, inflammation rises, the nervous system becomes more reactive, and the cycle continues. Pain disrupts sleep, poor sleep worsens pain, and in chronic pain, improving sleep, therefore, is not optional, but it is actually treatment. Some patients require evaluation for sleep apnea. Now, this is important for two reasons. One, because poor sleep worsens pain amplification. And the second, more importantly, is in patients on long-term opioid therapy, sleep apnea increases the risk of respiratory depression. So sleep testing is not just about fatigue, it is part of pain assessment and risk stratification. And finally, what are these targeted special testing which we can do? There are some situations where specialized testing is appropriate. For example, if you suspect fibromyalgia, use ACR criteria-based tools such as WPI, which stands for Widespread Pain Index, or SSS, Symptom Severity Score. And these help quantify pain distribution, symptom burden, and in select patients, particularly those with burning pain, dysesthesias, mood changes, and a normal EMG. And sometimes you may have to consider skin biopsy in these individuals as well to evaluate for small fiber neuropathy. And this is all targeted testing, and it's not blanket testing, and it's not ordering everything and hoping that something would be positive or something sticks. So before ordering broad panels or imaging, pause and ask, have I fully understood the patient in front of me? Best practice in chronic pain management is to recognize an underlying sequence with a stepwise approach to diagnosis, which includes history, physical exam, acknowledging comorbidities, recognizing a pattern, and eventual diagnosis of pathology, because often the diagnosis is already there. So let's talk about labs. Labs are not routine in chronic pain, but they're targeted. Order labs when you suspect inflammatory conditions, metabolic contributors, or systemic disease or neuropathy. For example, ESR, CRP, rheumatoid factor, ANA, uric acid, vitamin B12, vitamin D, TSH, and even A1C. Remember, normal labs do not rule out pain, but abnormal labs do not always explain it either. Imaging is one of the most overused tools in chronic pain. But like I said, treat the patient and not the MRI. Most common imaging modalities are X-ray, MRI, CT scan. But when is it helpful? It's helpful when you suspect red flags, progressive neurologic deficits, or you want to do a pre-procedural planning for interventions, or failure of conservative care with focal findings. But when does imaging mislead? When you see degenerative changes, which are common, disc bulges, facet arthropathy, foraminal narrowing, which often reflects aging, and they may not be the pain source. These are often signs of aging and do not always indicate pathology. However, if the imaging doesn't match the exam, trust the exam. For instance, if patient has facet loading test strongly positive on the patient, along with lumbar axial pain, functional limitations, and facet arthropathy, then the patient likely has nociceptive pain which requires treatment. Nerve conduction studies and EMG are useful. These are specific targeted tools and not screening tools. Indications: radiculopathy, peripheral neuropathy, entrapment syndromes. But what they show are nerve localization, severity, chronic versus acute changes. But what they don't show is they do not measure pain. A normal EMG does not mean no pain. It does not mean the patient is fine. Use these tests to confirm and not to broadly screen. Now, one of the most important and clinically useful tools are diagnostic blocks. Diagnostic blocks answer one question: is this structure actually the pain generator? Examples are facet medial branch blocks, SI joint injections, selective nerve root blocks. If pain improves after the block, that structure is likely contributing. The relief must be significant, reproducible, time appropriate, but be careful of limitations such as placebo effect, spread of anesthetic. Diagnostic blocks do not address other pain generators where patients have multiple pain sources. And diagnostic blocks are certainly not decision tools. They're not treatment endpoints, and they're certainly not the final answer, but they're very good tools in understanding the pathology. A good diagnostic workup is not about ordering everything and anything, but it's about layering information. Start with history, exam, targeted labs, selective imaging, and then confirmatory testing when needed. Think in systems: structural, neurologic, inflammatory, central sensitization, and so forth. The key point here is to pay very close attention to comorbidities, friends. Chronic pain is not a single diagnosis. It is a complex interaction between tissues, nerves, and the brain. And your job is not just to find abnormalities, it is to determine what actually matters. Clinical reasoning outperforms excess testing. Interventions in chronic pain management. So far, we've talked about diagnosis, understanding the patient, understanding the mechanisms, and understanding the system. But diagnosis is only the beginning, because identifying pain is not the same as treating it. The real question is, how do we intervene in a way that is more effective, in a way that is more targeted, and a way that is more sustainable? Chronic pain treatment is not one tool. It is a spectrum, from medications to procedures to rehabilitation to behavioral strategies. And most importantly, it requires matching the intervention to the mechanism. Because if you treat the wrong mechanism, you get the wrong outcome. So in the next section, friends, we'll break down what are the different interventional procedures, when to use them, when to order them, who benefits most, and how to integrate them into a comprehensive plan, not just reducing pain, but improving function and restoring quality of life. This is Pain Policy Practice, where we address the system to improve the experience. It is where clinical reasoning drives better care, and better care improves lives. Bye.